Ohayo gozaimasu and welcome to my audio medical basics where I read medical books to your ears when your hands are too busy to hold a book. If you like, please don't forget to like, share and subscribe. So today we'll move on with the case files book with the Pediatrics case file book, and we'll read one case from this book inshallah from my collection of case files. Today's case is about the failure to thrive. So I'll read the full case, which is very short here. A mother brings her 12-month-old child, a new patient for your clinic, for a well child visit. The infant appears to be small for her age. Her weight is below the 5th percentile on the standardized growth curves. Her length is at the 25th percentile and her head circumference is at the 50th percentile. Her vital signs and her examination otherwise are normal. What is the next step in the management of this patient? What is the most likely diagnosis? And what is the next step in the evaluation? So, summary. A 12-month-old girl has poor weight gain, but no etiology is found on examination. So the next step, gather more information, including birth, past medical, family, social, and developmental histories. A dietary history is especially important. What is the most likely diagnosis? It is failure to thrive, most likely non-organic in this case. Non-organic and etiology. Next step in evaluation, limited screening laboratory testing to identify organic causes of failure to thrive, dietary counseling, and frequent office visits to assess weight gain. So the objectives of this case is to know the historical clues necessary to recognize organic and non-organic failure to thrive, to understand the appropriate use of laboratory in a healthy child with failure to thrive, and to appreciate the treatment and follow-up of a child with non-organic failure to thrive. Considerations. The patient's growth pattern, which is inadequate weight gain, potentially modest length retardation, and head circumference sparing, suggests failure to thrive. Most likely non-organic, given that the examination is normal. A non-organic failure to thrive diagnosis is made after organic etiologies are excluded and after adequate nutrition and an adequate environment is assured. Growth resumes normally after catch-up growth is demonstrated. Diagnostic and therapeutic maneuvers aimed at organic causes are appropriate when supported by the history. Prematurity, maternal infection, also if supported by the examination, such as enlarged spleen. So diagnostic and therapeutic maneuvers aimed at organic causes are appropriate when supported by history and examination. Although organic and non-organic failure to thrive can occur simultaneously, attempts to differentiate the two forms are helpful because the evaluation, treatment, and follow-up may be very different. Note, had the same practitioner, in this case, followed this patient since birth or had previous records from the previous healthcare provider, earlier detection of failure to thrive and its potential etiology with rapid intervention might have occurred. For instance, patient with poor caloric intake usually fails to gain weight but maintain length and head circumference. As nutrition remains poor, length becomes affected next and then ultimately head circumference. So this is important. If the practitioner in this case followed this patient since birth or had previous records from the previous healthcare provider, earlier detection of failure to thrive and its potential etiology with rapid intervention might have occurred. For instance, patients with poor caloric intake usually fail to gain weight but maintain length and head circumference. So poor caloric intake, fail to gain weight, but maintain length and head circumference. As the nutrition remains poor, length become affected next, and then ultimately the head circumference become affected. So the definitions. What is failure to thrive? Failure to thrive is a physical sign, not a final diagnosis. It is suspected when growth is below the third or fifth percentile or crosses more than two major growth percentiles in a short time frame. Usually seen in children younger than 5 years whose physical growth is significantly less than that of their peers. That is failure to thrive. So we have two types, non-organic and organic. Non-organic failure to thrive is poor growth without a medical etiology. It is often related to poverty or poor caregiver-child interaction. It constitutes 1/3 to 1/2 of the failure to thrive cases identified in tertiary care settings and nearly all cases in primary care settings. And organic failure to thrive is poor growth caused by an underlying medical condition such as inflammatory bowel disease, renal disease, or congenital heart conditions. Clinical approach. The goals of the history, physical examination, and laboratory testing are to establish whether the child's caregiver is supplying enough calories, whether the child is consuming enough calories, and whether the child is able to use the calories for growth. Identification of which factor is the likely source of problem helps to guide the management. Diagnosis. The history and physical examination are the most important tools on the failure to thrive evaluation. A dietary history can offer important clues to identify an etiology. The type of milk, either breast or bottle, and frequency and quality of feeding, voiding, vomiting, and stooling should be recorded. The milk used, commercial or homemade formula, and the mixing process to ensure appropriate dilution should be reviewed. So the milk used and the mixing process should be reviewed. Why? Adding too much water to powdered formula results in inadequate nutrition. The amount and type of juices and solid foods should be noted for older children. Significant food aversions might suggest gastric distress or malabsorption. A 2-week food diary and any associated symptoms of sweating, choking, cyanosis, difficulty sucking, and the like can be useful. A 2-week diary, the parent notes all foods offered and taken by the children. So if you note for 2 weeks all the foods offered and taken by the children and any associated symptoms of sweating, choking, cyanosis, and difficulty sucking, and such can be very useful. Pregnancy and early neonatal histories may reveal maternal infection, depression, drug use, intrauterine growth retardation, prematurity, or other chronic neonatal conditions. When children suspected of having failure to thrive are seen in families whose members are genetically small or with a slow growth history, which is constitutional delay, affected children are usually normal and do not require an exhaustive evaluation. In contrast, in family history of inheritable disease associated with poor growth, example cystic fibrosis, should be evaluated more extensively. In contrast, a family history of inheritable disease associated with poor growth should be evaluated more extensively, such as cystic fibrosis. Because non-organic failure to thrive is more commonly associated with poverty, a social history is often useful. The child's living arrangements, including primary and secondary caregivers, housing type, caregivers' financial and employment status, the family's social supports, and unusual stresses, such as a spousal abuse, should be reviewed. While gathering the history, the clinician should observe for unusual caregiver to child interactions. Okay, this is all for part 1 of failure to thrive, and we'll continue inshallah in part 2. And don't forget to like, subscribe, and comment. And thank you very much.